Ms. Karin Flyckt is joining us this evening from Sweden to share best practices in supporting mental health of vulnerable groups during and after the pandemic. Ms. Flyckt is also a senior advisor at the Swedish National Board for Health and Welfare for the area of disabilities. We are very excited to be able to learn from her. Dear Karin, nice to see you again. How are you?
I'm fine, thank you. Nice to see you again. How are you?
Well, a bit tired, but very happy to learn from you.
Yes, but it's so nice to get this invitation. Thank you very much for inviting me.
Hopefully next time it will be live in Croatia.
Yes, fingers crossed. Yes, so do you want me to start the presentation? Yes.
Thank you.
See if I manage to share the screen. I have a presentation, and I will. I don't know how long I will. How long the presentation will be. We'll just see, but I don't think it will be more than 30 minutes or something like that. Here we are. Yes, I think so. So can you see the screen, the presentation?
It's perfect.
Perfect, thank you. If you have any questions during my presentation, just write them in the chat form, and maybe you can just tell me that, read the questions out loud or something. And then also, of course, if you want to ask any questions after my presentation, that's just fine as well. The topic for today is for my presentation is mental health among vulnerable groups during and after the pandemic. Sirdik, I don't know what happened here. Autocorrect misspelled it, but it's Swedish experience and best practice. So I would like to share with you the Swedish experience regarding mainly the elderly and persons with disabilities. And first, just a few words about myself, and thank you, Elle, for the presentation. I work at the National Board of Health and Welfare in Sweden, which is a department under the Ministry of Social Affairs. I am a senior advisor in disability issues. I'm also a national coordinator on disability issues, and during the pandemic, I've been quite busy with the COVID-19 related challenges and tasks, so I've been mainly working with these issues for the last 2 years. But first of all, just a few words about Sweden and the Swedish system and the national board. First of all, how Sweden is governed. Well, of course, we have the parliament that represents the people. We have an election every 4 years, and it's the parliament that has the legislative power. And we also have the government, which my agency is a part of. The government enforces the decisions of the parliament and develops proposals for new laws and amendments to legislation. It's assisted by the government offices and a number of ministries and government agencies. And government agencies shall practically implement the decisions made by the parliament and the government. And this is, I don't know if it's unique for Sweden, but it's not that common, I think, that the government agencies act independently pursuant to the government guidelines. So the government cannot control the agencies. The government cannot intervene in ongoing work, etc. But of course, it's the government that gives that controls the budget and assignments, etc. But still, they cannot intervene in ongoing work. And then we also have the regional level, which consists of 21 counties. Each county, there's a county administrative board that act as the government's regional representative. And on a regional level, we have healthcare, social planning, etc. We have dental care, rehabilitation, and a majority of the prescriptions of assistive devices. So that's the regional level. And the activities on this level are primarily funded from county council taxes, and to some extent from fees and government grants. Yes. And then we also have the local level, the municipalities, and we have 290 municipalities in Sweden. And also the municipal council is elected every 4th year. And the municipalities are responsible for schools, preschools, care of the elderly and disabled persons, individual and family services, roads, water supply, etc., etc. And the activities on this level are also financed primarily from municipal taxes and partly through government grants and fees. And so this is the level where all this, where all the services for the elderly care and services for persons with disabilities are implemented. This is where the responsibility is, and also, but when it comes to healthcare and mental health, the responsibility is it's a responsibility of the regions and the hospitals, etc. So it's not on a local level. Yes, and the national board where I work is a national agency, as I said. And what we do, we do follow-ups, evaluations, etc., etc. We elaborate and develop knowledge, different kinds of knowledge, national guidelines and manuals, handbooks, etc., etc. We also develop norms based on legislation and knowledge, and lots of other public authority tasks. And we are the main national agency when it comes to social service and healthcare. The National Board of Health and Welfare during the pandemic, well, we have been, and we still are, a central agency, considering that we have been responsible for the coordination of the crisis management in the country, coordinating the regions and the healthcare and the intensive care, etc., etc. And we also coordinated the crisis management in the municipalities and social service, etc. Also, we've also coordinated the distribution of protective equipment, because I don't know about Croatia, but in Sweden for the first 3 or 4 months there was this huge lack of protective equipment. So we as a national body were pointed out as the coordinator of distributing this to the healthcare sector and the social services and municipalities. We've also since I think the first week of April 2020, we've had weekly updates with statistical updates on the number of cases with COVID-19 among vulnerable groups, number of deaths due to COVID-19, etc. So we've almost been doing this. We've been doing this for almost 2 years now, updating every Wednesday. And also this never-ending work of elaborating, publishing checklists, e-courses, Q&As regarding healthcare, elderly care, disability care, social service. Because also during the pandemic, it's first of all ensure that the hospital staff and the staff working at the elderly homes and residential houses for the disabled, etc., that they know how they have the knowledge they need to have in order to prevent people from getting sick with COVID, and all the basics when it comes to minimizing the disease. So we developed many e-courses about on this subject. We also published e-courses, regarding since during the pandemic and all the sick leaves, etc., staff being home due to symptoms or being sick with COVID, actually. There's been a huge demand for people who can fill in and just, maybe they don't actually, it has been so, from time to time, it has been so critical that actually we haven't been able to secure that the persons working at these housings and homes, that they have the relevant education. So we have also developed, crash courses, and just if you are new at this, if this is the first time you work in a home for disabled people, you need to know this and this and this and this. So just making sure that the services can be provided without too much effort. And we still do all this, even though we see, we have a lot of, due to Omicron, we have, the number of cases have been increasing for several weeks now, but things are getting better. But we will still, publish the statistics, and we are still coordinating the crisis management, etc. And we see what happens, because even though it looks a bit, we can see the light in the tunnel, but you never know what's gonna happen in a few months, because we still have a pandemic. Anyway, I will mainly talk about persons with disabilities, but I think that you can. I will also talk about elderly, of course, but I will focus on persons with disabilities. But I think a lot of things that I say you can also apply to the elderly group. So this slide says, why are additional considerations needed for people with disability during the COVID-19 outbreak? This is a pamphlet, a policy document published by WHO in, I think it was April or May 2020. So it was quite early in the pandemic. Well, anyway, WHO said that people with disability may be at greater risk of contracting COVID-19 because of barriers to implementing basic hygiene measures, such as hand washing, hand basin sinks or water pumps may be physically inaccessible, or a person may have physical difficulty rubbing their hands together thoroughly, but also difficulty in enacting social distancing because of additional support needs, or because they are institutionalized, and the need to touch things to obtain information from the environment or for physical support. Let's see here. And also, one other obstacle is barriers to accessing public health information. If you don't have access, if the public health information isn't accessible for you, how are you going to be able to prevent yourself from getting sick? People with disability may also be at greater risk of developing severe disease if they become infected because of the pre-existing health condition underlying the disability and barriers to accessing healthcare. So this is not just a question of the persons themselves, it's also an environmental issue, questions about how accessible is the healthcare system and the facilities. And also, I think this is also very important, that people with disability may also be disproportionately impacted by the outbreak because of serious disruptions to the services they rely on. And and also the barriers experienced by people with disability can be reduced if key stakeholders take appropriate action. So actually WHO highlighted these groups early during the pandemic. I would also like to add one thing, that I think that persons with learning disabilities, etc., also may have difficulties communicating, how, for those with limited limitations in their communication skills. If you cannot communicate, how are you going to communicate? Let's say you have difficulties breathing, you can't smell anything, you can't taste anything. So just the fact that they cannot, many of them have difficulties with communication can also be a factor. Yes, and all of this, I think I'll go to the next slide. Anyway, what happened in Sweden? I think the pattern in Sweden is very similar to many other countries, and probably also in Croatia, when it comes to the number of cases with COVID among the elderly and persons with disabilities. First of all, in Sweden, we haven't had any lockdowns, actually. Restrictions, yes, but not lockdowns, although we've had many restrictions. And but for persons with elderly persons and persons with disabilities, they of course they have been subject to the general restrictions, but there have also been other restrictions as well. And but also they are, after all, vulnerable groups, so it's understandable. Anyway, elderly persons, like above 70 or even older than that, elderly with underlying conditions, we've seen an increased mortality, especially among elderly with home care service or residential housing. And then also among persons with disabilities, younger persons, even though we could, the number of cases are low with COVID are lower compared to the population, but among those who got sick with COVID, a higher proportion died. And I think 5-6% of all the persons who got COVID, and among persons with disabilities living in residential housings actually died, and that's a bit more than among the population. So these are definitely vulnerable groups, but not only when it comes to getting really sick by COVID or actually die from COVID. It's also about the consequences. And yes, I will come to that. I will just tell you a bit about what we have been doing during the pandemic. I mentioned a few things. I will just say a few more words about it. Well, since March, April 2020, we have had weekly updates of our statistics, and it's about the elderly care, persons with elderly care, home care service and residential housing, and also persons with disabilities, personal assistance, which is a kind of advanced home care service, and residential housing. Every week we published a number of cases with COVID-19 among these groups, divided by sex, age, and where they live, and the number of deaths divided by sex, age, and where they live. And also we published the place of death. Did they die at home? How many died at home, in residential housing, at hospital, etc.? Because knowing that it indicates how many of those who got sick with COVID actually got hospital treatment. So that's why we publish statistics on place of death. And just here's an example. This figure is very small numbers, but it's basically every staple is one unique 1 week. It's from March, beginning of April 2020. To the left, and to the right is the first week in 2022. And what we can see here is the unique number of cases with COVID among persons with disabilities living in residential housing. And as you can see, well, we have a large number in the beginning of 2020, and then also in the middle, you can see we have a quite high number of cases, you know, December and January 2020, 2021. And then also to the right, you can see all-time high the first week of 2022. So it's basically following the same pattern as the rest of the population, you know, Omicron and etc. But this has been really important in order to, you know, follow what happens and etc. etc. We've had so many dialogues and updates on a weekly basis, weekly notice with service providers and healthcare directors and social service directors and NGOs. And when it comes to the NGOs, we have the National Board has a Disability Council with representatives of disability organizations. I think we have 17, 18 organizations being represented in this council, and I'm responsible for it. So we usually have meetings like 4 times a year, discussing different, you know, topics, etc., etc. But we actually had separate meetings continuously just about COVID. And what they did, actually, they provided us with, you know, very updated and relevant information on how does it work out there from, you know, the person's perspective, the individual perspectives, from you know, how does it work with, you know, the vaccine and the protective equipment, and how many residential housing are banning relatives from visiting, etc., etc. So extremely valuable information, and also extremely valuable information from the service providers, because they gave us every week, they've given us their an update on how things are in their municipalities and regions. And also I think I think this is similar to all the countries in the world almost, but initially, of course, the National Board, we needed to focus on protective equipment, the distribution of protective equipment, also minimizing the number of cases among vulnerable groups, because people started to die, and they started to die, you know, fast pace, high pace. So we had to focus on that. But later on, not to, you know, after 6 months or something, when we realized, as the rest of the world did, that we will be stuck with this pandemic for some time, we started to focus on the consequences as isolation and mental illness, etc., among persons with disabilities, and not only mental illness among persons who have mental disabilities or, you know, psychosocial disabilities, but like psychosis, etc. But what we did focus on was mental illness as a consequence of the pandemic, the isolation, etc., etc. So what we did was, among many other things, we analyzed and evaluated, and actually did we didn't evaluate, we carried out a follow-up in all the municipalities to see exactly how are people doing, what measures have the municipalities taken in order to minimize COVID-19 and protect vulnerable groups, and what are the consequences for the persons themselves, etc., huge follow-up, just in order to gather information and get information on what's going on out there. So I think, after 6 months, we started to focus on the consequences also. And what we could see, and this is still valid, of course, and this goes for both the elderly and the persons with disabilities, at least some of these consequences. Huge isolation among vulnerable groups, and the groups that are already suffering from isolation, and usually they have few, social interactions and so on. So, and these groups, they have been subject, they have been affected by the general restrictions in the society, those restrictions that we all have been affected by, but also, daily activity centers closed down. Families and friends were banned from coming to see them at in the residential housings, they weren't allowed to see each other in the living room, etc., in the residential housings, in the group homes. Many of them, especially those with cognitive or intellectual, impairments, experience quite severe difficulties understanding what's going on, what's happening. So huge isolation, and also among persons living in, at home. It's not only the persons living in residential housings or elderly, homes for the elderly, etc. That's not the only ones who has been isolated. Also, persons with disabilities and the elderly who lives at home, they have been isolated as well. And this has led to an increased mental illness among these persons. And it's and what we know that partly from dialogues and from our follow-ups, but also by we have conducted several register analysis. We have analyzed our healthcare registers, and we have seen that the prescriptions of antipsychotic, antidepressive medications have increased, and etc. for these groups, among these groups during the pandemic. So, and the problem is, of course, mental illness is always a problem. But these groups are, many of these people, they already have an increased mental illness. It's very common among these groups. So this just adding up the problems, really. But also another consequence of the pandemic is an increased burden on relatives and next of kin, because they have it's quite common that they have helped out when the support from the municipalities have been limited, in etc. And these are few of the, and also of course limitations of support services and care. I think 30% of the municipalities just closed down all the activity centers, and it's, for example, and for a year and a half maybe, so it's been a long time. And the consequences, well, what we see is they're both short-term and long-term consequences. Some consequences will eventually just disappear when the restrictions are being removed, and when the pandemic also when it vanished sometime in the future. But anyway, but not all consequences will disappear by themselves. We believe that some of them will be there for a long time, and one of them is mental illness, and we're very concerned about that, both regarding the elderly and other persons with disabilities. also, we actually been taking action has been taken with, and here's some examples of measures taken from a national level. The government has decided on government grants to NGOs representing the elderly, and the government grants are targeting, the aim is to prevent isolation. So the government actually pays the NGOs to help prevent isolation among the elderly, starting different activities, etc., etc. Also, actually this week and the last week and this week, we have a national information campaign focusing on mental illness among elderly, because it's still such a stigma. So we have this information campaign. Videos are broadcasted on national television, in the waiting rooms of the healthcare facilities, etc., etc. We have published leaflets available at the healthcare centers, just trying to break down the stigma and encourage the persons to get help, to contact the GP, etc., etc. We also in the process of translating COVID-19 guided self-help booklets for persons with mild to moderate learning disabilities. And a few of the topics are coping with feeling down, coping with anxiety, dealing with anger. And these booklets can be self-help booklets, can be read and by the persons themselves, but there are also additional material for service providers, families and staff, etc. And I wish I could say that we came up with this idea, but we didn't. It's the University of Glasgow. It's a Scottish booklet series. But I think it's really brilliant, really brilliant. Targeting mental illness, and also I should say that they will be available in easily read format. That's the whole point of it. But what we also do is we carry out continuous analysis of mental illness among vulnerable groups, e.g. elderly and persons with disabilities, and for that, we use our healthcare registers, and I'm actually right now in the middle of analyzing suicides among persons with learning disabilities and other disabilities, suicide and psychiatric care, and etc., etc. During the pandemic, we're comparing the number of suicides, etc. With the years previous to the pandemic, just in order to gather as much information as we can. And we will continue to do that for a couple of years. So lessons learned and success factors, continuous dialogues with the NGOs. I must say that's been a really big success factor, because without them, we wouldn't have the updated information that we've actually had during the pandemic. We also lessons learned. I must say in success factor, I hope that in the near future I will be able to say that the information campaigns and the leaflets, etc., were success factors, were all success, but time will tell. Anyway, another thing, I haven't mentioned this, but we actually have a few psychiatric clinics in Sweden is targeting specifically persons with learning disabilities, and they've been really busy during the pandemic, and I think they've been so important for this group. Just not there's one thing, getting prescriptions on antipsychotic and antidepressant, but there are so much more in managing mental illness, and these psychiatric clinics have been so important. And also analyze, because without the analysis, we don't have the knowledge, and if we don't have the knowledge, we don't know what to do next. So I think that's it, actually. So, and with that, I'll just say thank you for listening to me. And here's my email address in case you for any reason would like to contact me. And yes, thank you for listening.
Thank you, dear Karen. This is such an important topic, and I wish to thank you again for willingness to set aside time for our symposium in your busy schedule. Last time we've talked, you were on a EU mission in Mauritius, if I remember correctly. So our deep gratitude for doing this pro bono.